All right, welcome you guys. For those of you who don't know me, my name is Eddie Watson, and this is ICU Advantage. If this is your first time to the channel, welcome. For the rest of you guys, welcome back. All right, in today's lesson, we are going to be talking about what is ECMO. Now, this is just going to be covering the basics of ECMO, but I've had a lot of people who've requested this video, so here we are. Now, ECMO is considered the pinnacle of life support. When we look at different varying levels of life support that we can offer to our patients, ECMO is the most advanced form. Essentially, when all others have failed, ECMO is the last thing that we have left. And if ECMO is not enough, then we really don't have any higher level of support to offer our patients. Now, you've probably heard of ECMO. You may even know a little bit about it, but in this lesson, I'm going to be covering the basics of what the therapy is, a little bit about its history, and then ultimately how and why it is that we use it today. And so with that, let's go ahead and get started. ECMO is an acronym that stands for a type of life support that we call extracorporeal membrane oxygenation, ECMO, ECMO. And this part here, extracorporeal, this means outside the body. Now, other examples of extracorporeal therapies would be things like hemodialysis, as well as some ventricular assist devices. But in its most basic definition, ECMO is oxygenating blood via a membrane oxygenator that's outside the patient's body. In reality, though, it is much more than just that. So before I talk more about what ECMO is, why, and how it is that we use it, I do want to take a quick look at the history. Now, there were many advances throughout history that ultimately led to the feasibility of ECMO today that we can really trace back all the way to the 1600s. I'm not going to cover all of those, but two big early discoveries that came about. The first one was in 1882, and this was the first use of a bubble oxygenator to oxygenate blood. Then following that, another big important discovery was 1916, and this was the discovery of heparin. This one was a really important factor in this because up to this point, one of the biggest problems that they were having in trying to be able to oxygenate blood was the clotting problems that they were seeing. So heparin was really a game changer on this front. Now, onto the timeline of ECMO specifically itself. The first thing is going to be in 1929. In Russia, they had the first reported extracorporeal perfusion of a dog. Then spanning from the 1930s into the 1950s, we had further development of the oxygenator, and this included things like the rotating disc oxygenator as well as the all-glass bubble oxygenator. Then one really big thing happened. 1953, we had the first successful cardiopulmonary bypass utilizing a bubble oxygenator. And here's an example of the type of machine that they were using at that time. Pretty interesting to see this technology here. A few years later, in 1958, they had the development of the first membrane oxygenator. It was this membrane oxygenator that really made things possible for ECMO and is still carried on in the technology that we use today. All right, so another really big milestone for ECMO was in 1971. We had the first true ECMO survivor. So this is actually a picture of him here. He was a 24-year-old male that was a trauma patient. He was involved in a car accident. And I believe he spent almost 72 hours on ECMO, and he ended up surviving. It's kind of interesting to take a look at this contraption, especially compared to some of the stuff that we have here today. Now, in 1975, they had the first successful neonatal use of ECMO. And this took place on an abandoned baby that the staff nicknamed Esperanza, who had a meconium aspiration. Now, she obviously survived ECMO, and very interestingly, here's actually a picture of her with Dr. Bartlett, who is the physician who did this for her. This picture was taken in 2019, so you can see how successful this was for Esperanza. And Dr. Bartlett here really went on to be one of the leading practitioners in ECMO for many, many years. Now, in 1978 was when they first described the removal of CO2 from the blood. Then, unfortunately, in 1979, there was a really disappointing randomized controlled trial using ECMO in adults with ARDS. And in this study, there was only a 10% survival. Now, ECMO continued with success in children, but largely fell out of practice with adults after this study came out. Then in 1989, an organization called ELSO, which stands for Extracorporeal Life Support Organization, was founded. They were founded with the purpose, and really continue a lot of this today, is in data collection and accumulation of best practices for patients on ECMO. And then jump forward to 2009, we had the H1N1 flu pandemic, and this led to a huge collection of data of the clinical successes that people were having with ECMO. Then also in 2009, we had the Caesar trial. And this trial was a multi-center randomized controlled trial that published their results in The Lancet. And essentially they were comparing conventional ventilatory support with ECMO in adult patients who had severe respiratory failure. And in this trial, it showed a pretty significant advantage in mortality for patients who ended up in the ECMO arm of the trial. Now, there were also some additional trials from that point till now, but this was really the big one that really kind of shifted the perspective, especially following that flu pandemic. All right, so with that out of the way, let's shift gears and begin to talk about how it is that ECMO actually works. In order to do that, we have to cover the configuration of a basic ECMO circuit. That way we make sure we're on the same page as we're talking about some of this stuff. So I'm going to go through and talk about the different parts of the ECMO circuit and what it is that they're used for. So the first thing we're going to talk about is the cannulas. And essentially the job of the cannula is to either drain or return the blood to or from the patient. Now, the cannulas come in many different sizes, many different lengths that really are dependent on the location that the cannula is as well as its purpose. But a couple main distinctions that we see. First is going to be in our venous cannulas. You'll usually find these ones to be the longer cannulas. And it's going to have multiple drainage holes along about 10 to 20 centimeters from the tip of it. And like I said, these ones are going to be our venous ones. Then we have these shorter cannulas. And these ones are going to be our arterial. These ones are definitely shorter than the venous cannulas, and they only have drainage holes right at the tip of the cannula. Now, both of these types of cannulas are going to be a pretty large size and wire reinforced to really kind of help it from collapsing on itself. Now, in addition to this, you can also see what we call dual lumen cannulas. And this single cannula allows both the drainage and the return, specifically for when we have patients on VV ECMO. This is something I'm going to talk about here in just a little bit, so if you don't quite understand that, just hang tight with me. Now, the next big part of the ECMO circuit is probably one of the most important ones, and this is going to be the pump. And the pump's job is to drain the blood from the patient and to drive it through the oxygenator, which we'll talk about here in a minute. Now, there's two different types of pumps that you can come across. We do have the roller style pump, which this is, if you've seen like on your CRT machine, that has the little roller that comes and pushes down on the tubing to move the blood along. The roller pumps are preload dependent, so it is important that we have adequate preload in order to prevent things like cavitation or pulling air out of the blood, but they are afterload independent. Now, the other type of pump that you're going to come across is going to be the centrifugal. And this is actually the most common one. It basically works by spinning things around, which helps to move the blood along. Now, these pumps, though, are both preload and afterload dependent. And as a result, we can't quite determine based on the RPMs that are going on that pump what our actual blood flow is. So one important thing with this pump is it's actually going to require a flow meter, which, again, I'll talk about in just a minute here. So now, at this point, we have coming from our cannula, we have the blood coming from our patient going to the pump. Now, the next piece of equipment and the next stop along the way for the journey here is going to be our oxygenator. And our oxygenator is something that we call a hollow fiber membrane. So if we take a look at a cross-section of this hollow fiber membrane, you can see all the fibers here. We can really think of these fibers like alveoli. And inside of these fibers is where our oxygen and gas is going to be flowing. And on the outside of these hollow fibers, this is where the blood is going to be coming through. Now, the gas exchange here is going to be taking place across the membrane of each of those hollow fibers due to diffusion of gas. And again, it's the pump that's driving the blood through this oxygenator. And then once the blood is oxygenated in that oxygenator, the blood is going to make its way back to the patient. Now, the next part I want to talk about is going to be attached to the oxygenator and really what gives it the gas that it needs for this diffusion. And that's going to be a combination of our blender and our flow meter. The blender and the flow meter is where we're going to have both our oxygen supply and our medical gas supply attached to. And it's going to allow us to adjust the FiO2 anywhere from room air at 21% all the way up to 100%. And this takes place in the blender. And then we have the flow meter, which is going to control our sweep gas flow anywhere from 0 to 10 liters. And this is what controls the amount of gas that we have going through the oxygenator. The next part that I want to talk about is going to be our heat exchanger. Now, our heat exchanger, its job is to warm and cool the patient. Basically, we're going to have this filled with water, and its job is to regulate the patient's temperature up or down. And so what it does is it uses this either warm or cool water to either warm or cool the blood. And typically, this is going to be integrated into most oxygenators. Now, to go along with all this stuff, we're going to have some sort of monitoring system that is either a separate monitoring system or built into some of these ECMO pumps. Now, if you remember when we talked about the centrifugal pump, that one required a flow sensor, and we're going to see that sensor on the line going back to the patient after the oxygenator. And again, this is just to let us know the blood flow that we have going on in this system. Now, finally, in this circuit, there's 3 different places in which we're going to be monitoring pressures. The first is going to be the venous, which is right before our pump. And this one we should be seeing a negative value. This is basically the amount of work that the pump needs to do in order to drain the blood from the patient. Next, we're going to have additional pressure monitoring just before the oxygenator. And this one we should see positive value. And this one basically is measuring the amount of resistance anywhere from the oxygenator onward in the circuit. I'm actually going to come back to this one in just a minute, because then the final place that we're monitoring pressure is going to be just after the oxygenator, what we call the post-oxygenator. And again, this one should be a positive value. And this one is looking at the amount of resistance past the oxygenator to the patient. Now, both the pre-oxygenator and the post-oxygenator pressures are going to be important, because we're going to use these two together in order to calculate something that we call our delta P. And this is basically the change in pressure that exists across this membrane. And the reason this is important is it's actually going to help us identify clotting that's taking place in the oxygenator. So that's a good look at the circuit that we see here. So again, we have the blood coming out of the patient through a venous cannula. It's going to make its way past the venous pressure monitoring and go into our pump, which is then going to move it along through our pre-oxygenator pressure monitoring before it gets to our oxygenator. This is where the magic is going to happen. We're both going to get our sweep flow and our FiO2 in order to help with the oxygenation, as well as CO2 clearance, which I'll talk about here in a minute. As well as we have the heat exchanger working here to help to regulate the temperature of the blood for our patient. From there, it's going to come out the oxygenator past our post-oxygenator pressure monitoring, possibly through a flow sensor, and then back to the patient through an arterial cannula or back through a dual lumen cannula. So hopefully you kind of have an idea of what's happening, how this circuit is working, because now I want to talk about the different configurations that we have set up for ECMO. And basically our configuration is going to be based on the type of support that's needed for our patient. The first thing I'm going to talk about is what we call VV ECMO, and this stands for veno-venous. And you can think of VV ECMO as being our respiratory support. It is important, though, in these patients that they do have preserved cardiac function, because that's what's going to be propelling this blood around the body. Now, in VV ECMO, we're going to be draining blood from a vein and then returning oxygenated blood back to another vein before it gets to the heart. And so this then is going to lead the blood to continue on through the right side of the heart and ultimately the pulmonary circulation, and then it's going to work its way back into the left side of the heart, where it's going to be moved throughout the rest of the body. So basically we're going to be providing assistance in oxygenating the blood before it even enters the cardiac and pulmonary system. Hopefully this makes sense now on why we need to have that preserved cardiac function, because the heart is still going to be responsible for moving the oxygenated blood around. It's just that the lungs aren't working, so we're going to use the ECMO circuit in order to oxygenate the blood. Now, to help you see this, there's a couple different ways that we can show this. So we can have drainage that's taking place in the jugular and returning blood back to the femoral vein. And as you can see in both of these cases, we're going to have that oxygenated blood before it even enters the right atrium. Or like I said, if we're using one of the dual lumen cannulas, then we're actually going to return the blood back in through the same cannula in the jugular. And I'll kind of show you down here how this works. So here we have inside of our vena cava is going to be the dual lumen catheter, and it's going to be going right through the passageways, going across through the right atrium. Now, forgive me, this is a very simplistic drawing, but essentially we're going to have a few different spots in which we're going to be draining the blood, both in the superior as well as the inferior vena cava. And then there's a special outflow port that's going to be lined up just right in the right atrium to return that blood straight at the valve going into the right ventricle. This is a pretty cool setup that we have here. Really makes it easy just to use a single cannula for patients on VV ECMO, but this one is going to require inserting this cannula under fluoro to ensure that we get the proper alignment. All right, so next let's talk about VA ECMO, and this stands for veno-arterial. And you can think of this one as being our cardiac support. Now this one's going to provide both cardiac support, but you're also going to get the respiratory support for free because we have the oxygenator on the system. Now in this configuration, we're going to be draining the blood again from a vein. It's going to go through the circuit, get oxygenated, but then we're going to return the blood through an artery after the heart. We're essentially going to be bypassing the entire heart and lungs, providing both oxygenated blood and the perfusion of that blood for the patient. The reason here is because in this case, the heart is not working or not working effectively enough in order to be able to pump enough blood around the body. So we're going to take the blood out before it even goes into the system and return it afterwards at the end of this system, and that's going to be providing that flow or that perfusion that the patient needs. And then on top of that, we're going to be supplying oxygenated blood. Now, there's a few different ways in which we can have this one set up. We can drain from either the jugular or the femoral vein, and then we're going to return the blood to the patient back through the groin, this time in an artery. And this is actually going to cause retrograde flow back up the aorta in order to fully perfuse the body with oxygenated blood. Now, you can also see central cannulation. This is going to be the type of cannulation like you'd see on a patient on bypass in the OR. And this is where they're going to have an open chest, and we're going to have cannulas right there in the vena cava as well as the aorta right there. This one, depending where you work, it may not be as common as just seeing like a fem-fem cannulation. Now, one quick note, if we do have the femoral cannulation, when we're in that artery, because of the size of the cannula, we really risk restricting blood flow to that extremity. We'll also see an additional line come off the ECMO circuit and go to something that we call a reperfusion cannula that actually goes in and goes the rest of the way down this leg. So again, VA ECMO, we're going to be pulling from a vein, going through our ECMO circuit and getting oxygenated, but then returning to an artery after the heart. Now, these are our two basic ECMO configurations that we're going to see. There are other configurations, but really for this lesson, that's going to be on the scope of what I'm going to talk about here. All right, so now let's talk about why it is that we would use ECMO for our patient. So we're going to be using ECMO in patients that either have severe respiratory or cardiac failure that have a high risk of death. We want to consider ECMO in patients that have a 50% mortality, and it's really going to be indicated for those patients with 80% or more. And then in these patients, one of three different situations has to exist. It has to either be a reversible condition, or using ECMO as a bridge to a device, or to use ECMO as a bridge to transplant. And the reason to understand this and to really kind of think about why this is because ECMO is not any sort of treatment. ECMO is not going to fix the underlying problem of whatever's going wrong with our patient. It's merely a form of life support that's going to allow us time either for our patient to heal naturally so that we can come off, or in the cases of a device or some sort of transplant, to buy us time in order to be able to either implant a device or to be able to get an organ transplant. So again, really key takeaway here, ECMO is not a treatment. It's not going to fix your patient. So let's talk about some of the reasons why we would use this for respiratory support. So in this case, our VV ECMO. And our three main reasons that we're going to be using it here is going to be for either hypoxemic respiratory failure, hypercapnic respiratory failure, or as a bridge to a lung transplant. So in the case where we have a patient in hypoxemic respiratory failure, we really want to be considering it if we see a PF ratio that's less than 150, and it's really going to be indicated for those with a PF ratio less than 100. For the patients that we have in the hypercapnic respiratory failure, we really want to be looking for patients that are having an impact on their pH, so their pH is less than 7.2, as well as when other kind of standard ventilatory strategies have really failed for this patient. And then the bridge to lung transplant, I think, is pretty self-explanatory. Now, some of the common conditions that we see that would lead our patient into one of these three scenarios, this isn't obviously going to be an exhaustive list, but patients who have ARDS, have some sort of severe air leak syndrome like a bronchopulmonary fistula, pulmonary contusions, inhalation injuries, status asthmaticus, as well as graft failure after lung transplant. Now let's talk about some of the reasons that we would use VA ECMO for cardiac support. Now here we're going to see this for patients that are in refractory cardiogenic shock, refractory cardiac arrest, also known as ECPR, as well as a bridge to either a device or heart transplant. Now in the case of refractory cardiogenic shock, if we have 2 or more inotropes and or a cardiac device, this is what we're referring to here. In the case of our ECPR, here if we have no ROSC that has come about after 10 minutes, and we can get them cannulated in under 60 minutes. And then again, finally, the bridge to a device would be some sort of ventricular assist device, LVAD, BiVAD, total artificial heart, something like that, as well as a heart transplant. And so again here, not an exhaustive list, but some of the common conditions that would lead our patient to this point would be obviously cardiogenic shock, acute decompensated cardiomyopathy, a massive PE, if they've OD'd on some sort of cardiac depressant, if they have sepsis with profound cardiac depression, anaphylactic shock, and again, the acute graft failure after a heart transplant. All right, so those are some of the reasons that we would do ECMO, but let's talk about some of the reasons that we wouldn't, or what we call our contraindications. Now, again, this is not going to be a completely exhaustive list, but some of the things that would be contraindications for ECMO would be things like advanced age, if they have some sort of severe neurological dysfunction, as well as significant comorbidities like metastatic cancer, advanced cirrhosis, or chronic renal failure. Also, if the patient is in multi-organ failure, has some sort of non-reversible illness without a bridge as an option for them, if they have contraindication to anticoagulation, as well as morbid obesity. Now, some specific conditions that would preclude our patient from getting VV ECMO would be things like chronic severe pulmonary hypertension, if they've had a prolonged mechanical ventilation with high pressure and high FiO2 for more than 7 days, as well as advanced shock. And for VA ECMO, it would again be things like advanced shock, aortic valve incompetence, or an aortic dissection. So those are the reasons and why we would be using ECMO. Hopefully that combined with, talking through the circuit and the different configurations, that it makes sense. Why would we be using it? How would we be using it? And in what conditions we would find our patients that this would be potentially beneficial or would really prevent them from being able to get this therapy. I was initially going to include it in this lesson, but I'm actually going to make a separate lesson specifically looking at some of the basic physiology that's related to our patients on ECMO, so make sure and stay tuned. That's going to be a video coming up here. Otherwise, if you guys enjoyed this video, please leave me a like. It really goes a long way to help support this channel, as well as subscribe if you haven't already. Head down in the comments, let me know any questions that you have or what you liked about the video. I love reading your comments. I try to respond to just about everybody on here, as well as a special shout out to our awesome Patreon subscribers. Your guys' support really goes a long way and it's really appreciated. So thank you guys so much. You guys get additional content that comes along with being a part of the Patreon page. So if you're interested in showing additional support beyond just watching the videos here on YouTube, make sure and head on over there and check it out. In the meantime, watch a couple of these really awesome videos I've linked to right here for you guys, and you guys have a great day.